Hi, everybody. Welcome to our first BU CTE Center Unite Brain Bank webinar. My name is Madeline Uretsky, and I'm the Research Program Manager and one of 5 brain donation coordinators, some of whom are on the call tonight at the CTE Center. It is my pleasure to welcome you all here this evening for what will be a very informative presentation. We hope. Feel free to type your questions and comments in the chat as we go, or save them until the end during our Q&A. Several, again, of our research staff are here, and on behalf of our team at the BU CTE Center, we are really grateful for your attendance and for your interest in our work and your help in our work. So it is my honor to introduce Dr. McKee. She is board certified neuropathologist and neurologist and has many titles, including the William Fairfield Warren Distinguished Professor of Neurology and Pathology at the Boston University School of Medicine. She directs the BU CTE Center, Unite Brain Bank, BU Alzheimer's Disease Research Center Neuropathology Core, the Framingham Heart Study Brain Bank, and is Chief of Neuropathology for VA Boston Healthcare. She's also a member of the National Academy of Medicine, and her research over the past 15 years has really led the field in chronic traumatic encephalopathy, or CTE. She has been instrumental in changing public awareness regarding the late effects of concussion, subconcussion, and blast-related injury, and her work was fundamental to defining the neuropathological diagnostic criteria, staging scheme, and correlations of CTE to clinical symptoms. And as such, she has received many awards, including the Samuel J. Heyman Service to America Medal, aka a SAMI Award, and was named Bostonian of the Year and one of Time's 100 most influential people in the world. And so it is my honor and pleasure to introduce Dr. McKee, and take it away.
Oh, thank you, Madeline. Thank you for all those kind and laudatory words. But the real purpose of this talk tonight is to talk to you guys that are out there in the field, the ones doing the hard work, the medical examiners, the coroners, the autopsy professionals, because none of the work that we do here at the BU CTE Center, none of the papers that we've written, none of the advances in science would be possible without the brain donations that you help facilitate. And so we are just enormously grateful to you for your involvement in the work over the last nearly 15 years. And I'll just skip through. I want to just say that Madeline and Amanda are here as part of our team. And Evan, I can see there are a few others on the call. But we this work takes a village of people. It requires 24/7 attendance to phone lines, being available for donations, which I don't have to tell you come in at any hour of the night, any day of the week. And we have a huge team of very committed people that I'm very, very proud to work with on this initiative. Just very briefly, I work with 3 other neuropathologists, John Cherry, who's a pathology research faculty. We work with clinicians, postdocs, students. We have MD, PhD students, histologists, and many, many research assistants. So it's a big group that helps coordinate the brain donation, and then when it comes in, the processing and the tissue storage and distribution of the tissue. We've been very involved in work on CTE for the last 14, 15 years. Our whole focus has been on the long-term consequences of brain trauma, especially not just concussion. Everybody thinks it's concussion, but it's also those subconcussive hits. They're asymptomatic, players play right through them. People don't realize that over time they can be injurious. We're trying to understand those repetitive hits to the head. And they can come through contact sports, but it can come through interpersonal violence, military service, a whole host of things. We have focused on CTE, and I think our center leads the world in the science of CTE. And again, it's all based on brain donation. We would be nowhere if we didn't have the help of medical examiners, coroners, and others helping us bring in these brains. We're very honored to do this work. We keep the brain forever. We don't ever throw anything away. So once we've done the analysis on a particular case, we continue to store the brain, either fixed or frozen, in perpetuity. So the brain bank keeps getting bigger. We keep having to have more and more freezers, more and more space, as over time we've collected so many brains. What we know about CTE now is we knew about 100 years ago that it affected boxers, but in the last 14 years, we've determined it also affects certainly American football players, but soccer players, rugby players, ice hockey players, wrestlers, both amateur and professional wrestlers, MMA, boxers, as well as military veterans who've had a history of trauma to the head. It's not an elite athlete that's at risk, or I should say it's not only the elite athletes, it affects amateurs. And it's not a disease of old age. This is a disease of youth. And that's why we're talking to you tonight, because it's very difficult for us to do this work knowing that this disease could be prevented, knowing that these young people in their 20s and early 30s are cut down at the prime of their life by a disease that could be prevented. That's why we keep doing this work, why we can't give up in trying to make sports safer and trying to bring hope and effective treatments to people who have CTE. So CTE is defined by a buildup of tau protein in the brain. But what we've found over the last few years is, in addition to the tau protein, which is very important in terms of producing symptoms, there's other changes in the brain that we know a lot less about. And one of those is white matter degeneration. So the interior of the brain, where the fiber tracts are crisscrossing, connecting all the nerve cells. We see a deterioration in the white matter. And we think that's one of the earliest features. We see it in young people, teenagers, 20-year-olds who've had repetitive hits to the head. We think it's important, but we can't determine how important it is until we get more controls. It's very hard to study the brain of normal people because people don't think of donating it if they've never had any problems. If their loved one never had any problems, they don't think that the brain donation might be of benefit to science. And this is precisely why we have very few control brains, and we have extremely few young person brains between the ages of 16 and 50. So young age to middle age, we have a dearth, a real lack of people who were leading normal lives and then died accidentally or otherwise and donated their brains to science. So tonight is a real plea, not just for those brains of athletes that you've been so kind to help coordinate those donations, but we're also looking for brains now from people 16 to 50 who were not athletes, who never had brain trauma, who died accidentally of something or other, and whose family might be interested in donating their brains to science. We can use these brains to compare the affected brains to the non-affected brains. And this is the next frontier for us, really understanding the very earliest changes that occur in these brains and occurs in really young people. So what are the symptoms of CTE? They're memory loss, impaired judgment, impulse control problems, depression, suicidality, and in late stages, Parkinsonism and dementia. But it's not just a disease of old age, and this is where it differs from Alzheimer's disease and Parkinson's disease. It is a disease of youth. It starts in the young ages. We've seen it as young as 17, and we have almost 200 brains from individuals under the age of 34 whose brains have been donated, and about half of those individuals have CTE. So we're really focusing now on these young people, both those who are exposed to head trauma and those not exposed. So the brain bank we call the Understanding Neurologic Injury and Traumatic Encephalopathy Brain Bank. It's located within the BU CTE Center. We harvest brain, and if the family agrees, spinal cord and eyes, trying to understand the long-term effects of trauma. Our major goals are to help people that are living by developing diagnostic tests so that we can accurately diagnose CTE in living people. We're looking at genetic risk factors. Why do some people get it more easily than others? And that's probably genes. And it's not just one gene. It's not going to be a simple, if you have this gene, you're more likely to get it. It's going to be multiple genes, some that make you more susceptible, some that make you less susceptible. And it's going to be this intersection of all these multiple genes that give rise to risk. We know there are other environmental risk factors. People talk about things like alcohol and substance abuse a lot. All of our research to date has not shown these to be substantial risk factors, but we need to know this completely. So we were interested in brains from people that died from overdoses, from alcohol or substance abuse. Those will be important factors for us to look at and compare to the CTE brains. As I said before, we store the tissue optimally forever, both frozen and fixed. Qualified researchers can apply to our center, and we will share the tissue de-identified. We don't give out any personal information, but it will be shared with other researchers all over the world. And we share our data and our resources with a national agency, which is called FITBR, a federated interagency registry on traumatic brain injury. And that data is available to researchers all over the world. So we're doing the gathering, we're doing the preserving, but we are interested in distributing tissue to everywhere because that is what accelerates science. It accelerates science if you can share the resource widely with qualified researchers, and that will cause scientific knowledge to increase as fast as possible on CTE. And just a few data points. We've had over 1,250 brain donors since we started in 2008. Almost all of them are men. We're really trying to recruit women. So please think about it. If you have a death in a young woman between 16 and 50, she might be a good brain donor, whether or not she played contact sports or not. We are interested in these young brain donors. We do get a lot of suicide in our bank. Overall, about a quarter of these deaths come in from suicide. And in the young people, it's the leading cause of death. The majority of deaths in the young people under the age of 35 come in from suicide. We've diagnosed CTE in many athletes, including football players. We get more football players in the bank than any other sport. But again, it's not just the pro players, it's high school players, it's college players, and semi-pro players. So you don't have to be a professional player. And we've also seen it in military veterans, not nearly as frequently, but we definitely see it. And we need, so if those brains are coming into you, please consider talking to the family about donating to the center, because we're extremely interested in military veterans. Just to give you a snapshot of the donations over the years, when we started out, we got very few, a handful a year in 2008. And then in the last 4 or 5 years, we average somewhere between 150 and 200 a year. This is quite a lot. This is obviously like 3 to 4 a week. So that's that's a very brisk pace considering this comprehensive analysis that we do for each brain. And if you look at the publications on CTE, just a reminder that they reflect brain donations. This is advancing science because of work on donated tissue. When we started the bank, almost no literature on CTE. And over the years, as the brain donations have increased, there's been a tremendous increase in the publications on CTE throughout the world. Recent publications include a dose response, that is for every 3 years of playing football, your risk for CTE doubles. We know that problems with cognition, memory loss, executive function are extremely important symptoms in CTE. And we had a recent paper about NFL players being almost 4 times more likely to develop ALS and die from ALS than the general population. But we've had many, many publications. These are just a few of the most recent. I wanted to show you one case. This is obviously a case that's very important in the New England area because everyone knew Aaron Hernandez, an outstanding player for the New England Patriots, and everybody knows, or many people know, the saga of his downfall. It was part of Netflix, and this is a brain coming into the donation from the medical examiner here in Boston. Sorry, these are advancing on their own. And this is my colleague, Victor Alvarez, and we're doing that initial exam just to show you Aaron's brain. When we looked at it grossly, it looked entirely normal. It weighed 1,573 grams, which is normal for these NFL players. They're big guys, and they often have big brains, and Aaron was no exception. There were no abnormalities when we looked at the brain grossly or with your naked eye, but as soon as we started doing the dissection into the brain, we could see that it was very abnormal for such a young man. There's tremendous ventricular enlargement. Sorry, these are flipping ahead. And this extreme thinning of the fornix, very unusual in such a young person, but definitely abnormal. And then when we looked to the side, we could see there were actual holes or perforations in the fornix. And this was very good evidence that we were going to see something when we looked at the brain microscopically. And then, of course, we did look at the brain, and this is 4 different sections of the brain showing, I don't know why this is doing this, showing of classic pathology for CTE. The neurons are filled with tau. It appears as this brownish reddish pigment. They circle around small blood vessels. And this is exactly the appearance of CTE, that tau abnormality circling around small blood vessels in the cortex, the gray matter of the brain. And here you, oops, now I'm really mixed up. Here you can see his brain was riddled with CTE. To be 27 years old and see that much brown pigment, all abnormal, all representing tau, is extremely unusual. But there's no question in my mind that this degree of pathology affected his behavior. How it affected his behavior is a little less clear, but I have no doubt that it contributed to some of his aggressive tendencies, his impulsive tendencies, and even, his suicidal tendencies. This is a huge amount of pathology in such a young person. And remember, his brain looked on the exterior surface entirely normal. And we see just widespread pathology in his brain. We know there's lots of inflammation in CTE, and this is another thing that we're concentrating on. We're wondering if just the presence of this very pronounced inflammation can cause symptoms. And does this contribute to some of the disability of CTE? And then just another very pretty picture, but we're just looking at the different forms of tau and what kind of nerve cells it affects. And we're just, what we determined here is that most of the tau that's deposited early on in young people is what we call 4R tau. That's unusual, but it's that's the tau that we get predominantly in these young people. We are looking really closely at the brain donors that are young because we want to understand the earliest changes of disease. We have 160 that we are putting into a paper. And what we've noticed in these 160 brain donors, 159 brain donors that were under the age of 35, they were 34 and under, most of them committed suicide. Most of them were symptomatic, and many were diagnosed with CTE. So even though the most common cause of death was suicide, even though almost all of them were symptomatic, there were only about half that were diagnosed with CTE. And while that's an extraordinarily high percentage and definitely cause for concern, because most of these players were amateurs playing only as high as high school or college, what it tells us is that most likely these individuals develop problems even before CTE develops. They get symptomatic with depression, impulsivity, explosivity, paranoia, and suicidality even before CTE is triggered. So what is that? And that's where we need your help with controls. We need to look at the brains of people that have been exposed to head trauma and compare them to young people's brains that have never been exposed, to really drill down on what are the earliest changes of things going wrong. We think it's the white matter, we think it's the blood vessels, we see abnormalities in both of these regions, but to be absolutely certain what's what, we need the controls to compare it to. And then this is just showing you some blood vessels in these earlier cases, and you can see the brown pigment surrounding the blood vessels. This is called perivascular macrophages. We see a lot of that in these young people's brains. We think these are leaky blood vessels. There's a breakage of the blood-brain barrier. Things that shouldn't be getting into the brain are getting into the brain and causing it to be inflamed. We think this may be part of the cause of all those symptoms, but again, we really need the comparison brains to make that determination. And then, so this is why we need to study young donors that aren't exposed to repetitive head trauma, to really narrow down on the earliest changes, what I would call pre-CTE. We think they're important. We think they're very symptomatic and devastating to the person clinically. And we need to understand more about them so we can prevent them in living players, so we can look for them in living players, and so we can treat them in living players. As you all know, brain donation is time sensitive. We have 24/7, 365 days coverage. I'm giving you the phone number. Historically, we've based inclusion into the brain bank on head trauma exposure and tissue quality. Tissue quality remains very important, but now we're extending it. Importantly, I just want to talk about, again, what we're looking for now are these controls. 16 to 50 without a history of contact sports or brain trauma, all races, all genders, and you can really help us, and I think help keep sports safe, help these kids that keep coming into the brain bank. I know they're coming into your centers. Let's keep them alive. Let's keep them well. And we can do that by understanding these very early changes, understanding what they are so we can intervene and prevent them from occurring in the future. So I just want to thank you, and I'll leave it up to you if you have any questions. That's it.
Thank you so much, Dr. McKee. We actually do have a number of questions that have come in directly to me through the chat. So I'm going to start here. And what is the ideal quality of the brain to be received in, to be able to study it for CTE?
Well, ideally we'd get it fresh. Get it on ice. We get it on wet ice in a series of plastic bags. And then in a styrofoam container. I know that you may not have access to all of these things, but yeah, that's the best way to get it. If we can get it couriered in as soon as possible in the fresh state on wet ice, protected in plastic bags, protected in a styrofoam container, and then a bucket, and then a styrofoam container, and then a cardboard box. We get it air couriered here as soon as possible, and then we can not only fix it, which I know you can do at your centers, but we can freeze it. And the freezing is important because it allows us to do more with the brain. We can do RNA, DNA, genetic analyses, we can do biochemistry. It just gives us a little more options, and it expands what we can use the tissue for. If you can't do that, the fixed brain, the brain that's been fixed briefly in formalin, is also extremely valuable. And we're getting better and better at being able to get DNA and RNA out of a fixed brain. We're not entirely there yet, but we can do a lot with the fixed brain. So if you don't, if you can't get the brain to us fresh, either you don't have the equipment or the resources, fix it in formalin, suspended in a bucket for a couple of weeks, and then send it to us, and we can do a lot with that brain. But that is absolutely, these are the brains that have helped us with all of this research, and it's really been extraordinary what we can do and what we can learn from this.
Yeah, and to go off of that, one of the questions in terms of fixation, for whole brain donation, is there benefit to injection of formalin via cannula through the basilar arteries to assist with fixation preservation rather than just floating the brain?
Well, if you can do that, if obviously, yeah, perfusion, if that actually can get into the brain and get into the deeper parts of the brain, like the basal ganglia, that would just improve fixation. But again, just suspending it in formalin is fine. So you don't have to go to great lengths, but if you're so inclined, yes, that probably would improve fixation of the interior parts of the brain.
Okay. And would there be any benefit to taking photos during the recovery of the brain to show the growth state when the calvarium is removed?
That would be fabulous. That would be fabulous. There's so much that we don't know. We get the brain, but we don't see the calvarium. We don't know if there were skull fractures or abnormalities. We don't always get the dura. We can't judge whether or not there's been a subdural or an epidural because we don't get those things. So if you're inclined to take photos, that would be fantastic. It just gives us greater information and helps us with the case.
Mm-hmm. And what are the most common errors that occur during recoveries of brains? And the second part to that is, how can we as recovery staff improve our techniques?
Well, there's always the problem of deep saw cuts, but we can work around those. The deep saw cuts, the fingers that get in the brain, you have to sort of deliver a brain like a baby, try not to poke, just sort of waiting for it to come out, gently come out and, hold it in your hand. So those are the most common artifacts, finger pokes, pulling on the brain, stretching the midbrain, and deep saw cuts. But those aren't deal breakers. The things that are tough are when we don't get the whole brain, it's been cut, and if it's cut fresh and then you put in formalin as fresh sections, they tend to really get very, very wobbly and they're hard to reconstruct. Obviously, we don't want the brainstem torn from the rest of the brain. Sometimes that happens. We can do a lot with whatever you give us, even if it's a gunshot wound to the head. We can make a lot of determinations from that. I think the main thing is getting us as much tissue as possible. We get most frustrated, I'd say, when parts of the brain are missing. Sometimes they're very critical parts of the brain. And we totally understand that some brains are very soft and difficult to remove, and artifacts are just impossible to avoid. But those are the common things that we see. We do get brains that aren't fixed. We get brains, that aren't put in fixatives, so that's not good because they get, autolysis and even in some cases putrefied. We don't want brains that are frozen. So some people sometimes think that if they put it on dry ice and it becomes a big block of frozen brain, that's going to be helpful. That's very, very hard to deal with. So please don't do that. It's better off to just fix the brain than freeze it on block.
Yeah. Okay. And then the next question, I noticed on the tissue quality slide that there was a mention of life support. Why don't you take brains that have been on life support?
We're finding that by the time they call the case, by the time, this is it's always a judgment call when to stop life support, and it's not a perfect science. So it tends to be a prolonged interval. And what happens, unfortunately, is the prolonged agonal period, the terminal period while the brain is deteriorating, but they're on life support, we lose all ability to do immunostaining. The tau stains are completely negative. The beta amyloid stains are negative. Everything is negative. Even the Bilshowski silvers turn negative. So that's why and we can't answer the question, did they have CTE or not, because the stains just don't work. And so really it's to prevent frustration from the family who's waited now months and months, and then we tell them we can't tell because it was too prolonged a terminal period. So we're trying to avoid that. These brains cost a lot. We don't charge anything, but we support everything with grants. It costs thousands and thousands of dollars to work up every case. And it's always really frustrating, not only for us, but for the families to find out that it didn't work. So even though we're saying no up front, it prevents them from sort of having high hopes and then being disappointed later.
Yep. Okay. And then, so the next question we have here, also feel free to keep sending them to me or to Amanda or putting them in the chat. So does the BU CTE Center coordinate with the funeral director associations or organ and tissue banks as a means to gain tissue?
No, we don't. And we just have never been able to coordinate that. I think in part because of the delay involved. If it goes to organ donation, which is extremely important, obviously, there tends to be a long delay before we can get the brain removed. Once in a while, we can arrange it on a case-by-case basis where we can get both done, but the tissue donation, the organ donation obviously takes precedent, and it just gives us, it just tends to delay things by even several days. And that's the problem.
Yep. Okay, and then we have another question here that was put to everyone in the chat from, it looks like Dr. Junkersdorf. Is the perivascular brown pigment definitely iron? In my practice as a medical examiner, I often find the perivascular pigment to be PAS positive and PBR negative, suggesting lipofusion.
Yeah, it's a good question. We have seen that it is composed of iron, but I don't think iron is the only thing it's composed of. I wouldn't be surprised if we see myelin byproducts, lipofusin, as you suggest. We have not done a deep analysis of that pigment, and I'm sure it's many things. I can tell you, though, we see large amounts of it in these brains. So that's something we need to do.
Okay, and then the next one, as a presentation on young people and the mention of suicide as a frequent cause of death in young people, what is the neuropathology of suicide?
Well, we don't I can tell you the cause of death, but you can tell me that too. If it's hanging, jumping off a building, or gunshot. But in terms of the neuropathology of suicide, this is where you can help. We still do not have a clear idea about what suicide or suicidal tendencies looks like in the brain. No one has been able to do a study of that. We are still, in the dark ages in terms of predicting suicidal behavior and completed suicide. And it would be phenomenal if we could make headway into that. If we could understand changes in the brain that might predispose to suicide, that would be a fabulous outcome of this work with the controls plus these young people. Understanding suicidal ideation and the origins of this deep depression and hopelessness would be phenomenally important.
Yep. Okay. And the last question I have here, unless other people have some, feel free to turn on your cameras and put them in the chat. But how do the brains of females you've examined differ from the males?
Well, so far we've had very few females. As you can imagine, we have very few females who've had as much exposure to head trauma as we have males. And that's largely because women didn't play contact sports until Title IX in schools. They're only recently in the military. Historically, women haven't had the exposures that men do. And so in our bank, we do have women. They are usually young women, even younger than the men. So I think our average age is very low, even high teens. They tend not to have the years of contact sport play that men do. So we get soccer players primarily, sometimes field hockey, maybe cycling, other things, but they don't have the 10, 12, 16, 20 years of exposure that we see in ice hockey players or football players who started playing at the age of 4 or 5. So they have less exposure. And to date, we still don't have a woman athlete or military veteran with CTE. We don't know if that's a gender problem, if they're less likely to get it, or if it's just that they're younger on the whole and they don't have the exposure. That's something we'd like to answer, but we need more cases in order for us to answer that.
Yeah, great. And another one here, as someone who works in a medical examiner's office or who is around medical examiners and coroners, what are active steps we can take now in our facilities to ensure that brains are properly preserved for study?
Well, I think awareness from the very beginning. This is obviously something the family has to agree to. And, a lot of times when they're confronted suddenly with this death, they're confused, they're in a state of shock, and they're not ready to make any decisions about what might be done in the future with this brain. So I think the number one thing that you could do is preserve the brain as a fixed specimen if you think that there's a possibility that the family might decide to donate the brain in the future. If you were just to preserve it in fixative, this would be a situation where you're going to put it in fixative and then present the option to the family. Don't expect them to answer immediately. They need to think it over. They need to all the tragedy to settle in, and they may decide a week or two or even a month later that they want to make this death count. And that's what I would try to emphasize with the families, and it's certainly something that we see with our brain donor families. And Lisa McKee, who's on this call, and she talks to all the families. It's a way to make something good out of something that's tragic. It's a way for that person to live beyond their years. It's a way for that person to contribute to knowledge, contribute to the health and welfare of the world. And it's a way for them to live on. We don't throw out anything. We honor the tissue donation. We're very, very feel privileged to receive it. And so it's a way, you know, once the family's gotten over the just tragedy of the death, to think about it as a way of giving back or giving to future generations.
Yeah, and I think just to add on to that, something of note, particularly for those that do extractions and are involved with the medical examiner's offices on this call, is that we reject, you know, upwards of 40 or more cases a year because of this prolonged postmortem interval or tissue quality problem, when otherwise they would have been good cases to study, because the family maybe didn't think about it as soon as they should have or would have been able to. And then, you know, all of the organs, when you do your autopsy, of course, are then put together or put back in, you know, not in fixative. And so it's then hard to study. So that's one of the main reasons, as Dr. McKee said, is we want to be able to take more of those cases. And the only really way to do that is to just make the family aware early on in the autopsy process.
And also, if you preserve it, fix it with the, you know, just possibly sometimes if you think the family may change their mind, you know, just leave that option open. But I do want to emphasize one more time that we can't do this without you. We're just enormously grateful to the tremendous input that all of you have had in this work. And, you know, I'm proud of our staff. I'm proud of what we've done at the center. And I do think we've changed the world. And you know, I just want to, you know, make you realize that you're part of that. You're part of this transformation. You're part of the reason that we know so much more about CTE than we knew 15 years ago. And I want you to feel what we feel, which is this team spirit that we're really making a difference.
Well said. Any final thoughts or questions for Dr. McKee?
Anyway, I appreciate all your time and thank you for listening.
Yeah, thank you all for joining us tonight. If you have any further questions, feel free to reach out. My email is there, and we are planning on hosting more of these in the future. So look out for either emails on that or for more of our social media postings.